Hello, I'm Norman Swan. Welcome to this program, Fly In, Fly Out, a healthcare option. And it's coming to you on the Rural Health Channel. I'd first like to acknowledge that the program is being broadcast from the land of the Wango people of the Darug tribe, traditional custodians of the land and part of the wider Aboriginal nation commonly known as Eora. And we acknowledge their elders, past and present. Tonight our panel will focus on the fly-in, fly-out healthcare services which provide medical and allied healthcare to otherwise isolated communities. But as you'll find out, often these communities, or sometimes these communities, aren't so isolated but have different needs. But these services are vital to the provision of healthcare in rural and remote Australia. It's not just a narrative we're going to be giving you tonight about these services. It's also going to be, a bit of a how-to. If you're thinking about getting involved in one of these services, what should you watch out for? What sort of personality should you have if you're going to do what you're going to get involved? And if you're a member of a community watching us, say, on NITV and as well as the Rural Health Channel, what should communities do to engage better with their fly-in, fly-out services to get the most from them? Tonight's program is webcast, so you can log into the Rural Health Education website, rhef.com.au, and type your questions into the live talk tab box and then click submit. You can also email us, text, reach us on Twitter at rhef. Well, I'll come to that in a minute, actually. I've forgotten what that is. But the details are on your screen now. Send your emails to questions@rhef.com.au. Text us on 0408 408 932. But I'd particularly like you to phone us and share your experiences of fly-in, fly-out services, either as somebody providing it or as a member of the community who've experienced them, and tell us about the good, the bad and the ugly, if you like. And you can tweet us by following us on at Rural Health Ed, at Rural Health Ed. Any of these means will get to us, and we'll take your questions and comments or indeed stories. Let's meet our panel. Christine Barlow is a nurse who does contract fly-in, fly-out work for between 1 and 4 weeks, relieving staff primarily in remote Aboriginal communities, usually in the Northern Territory. Welcome, Christine.
Hi, thank you.
Tristram Duncan is a consultant psychiatrist, and he's also unit director of the Mental Health Rural Outreach Service, providing services and supervision to smaller towns across Western New South Wales Local Health District, using a combination of travel and telehealth. Welcome, Tristram.
Good afternoon.
Dr. Tonya Marquardt is a general practitioner and also senior medical officer in primary healthcare, located in Cairns, working with the Royal Flying Doctor Service, fly out into Cape York. Welcome, Tonya.
Thank you.
And David Poff is a staff specialist and retrieval physician with the Royal Flying Doctor Service in Western Australia, but he actually flies between Queensland and WA to do his work. Welcome, David.
Thanks.
And welcome to you all. Christine, how long have you been doing this?
A couple of years, fly in, fly out.
Right. What were you doing before that?
I work in Queensland in one of the big hospitals there.
Why did you start doing it?
Because I was interested in it, because in a few years' time back then, my husband and I were going to travel around Australia, and just through word of mouth, nurses where I worked.
So you thought it would be a good lifestyle as well as career option?
Yes.
Was it a bit of a shock when you started doing it?
It was probably the unknown, and I've gone out there.
You didn't know what was going to hit you when you got there?
No, exactly right. But with support, to go out there with orientation, that what I was given was very interesting, and I've built on it since then.
So tell me what would happen. You're not flying in for the day as a nurse and flying out. You'd fly in and stay for a while.
Yes. With myself, I'll stay in for up to, say, 4 weeks maximum, just relieving the nurses on the ground there for education or annual leave.
So you're not. So in a sense, you were being a locum rather than the only nurse that was going in for. In other words, no nurse, and you're a nurse for a while and then coming out. You were actually relieving an existing position.
Yes.
Usually.
Yes.
What did you? Tell me the most surprising case of you, like early on, the one that sort of made you realise this is a different world.
Oh, for example, in the big hospitals, you get your trauma and all your general problems there. But when I first went out to remote communities, one of the things that I'd never come across before, which is prevalent out there, is scabies, for example. you know, and it was a whole new learning curve for me on that particular ground. That was probably the biggest thing that stood out for me, something sort of simple, skin disease, but I hadn't come across before.
And what, and what about acute care?
Okay. I've pulled on my experiences from the big hospitals, so if anything acute happened in the clinic, it's very similar to what I'd experienced in the big hospitals. Of course, you don't have the facilities that you have available to you in the bigger hospitals.
And what sort of resources could you call upon, you know, in terms if you didn't know something or you wondered what the protocol was? For example, there's there's the CRANA manual for remote nurses, which is pretty good. I think a lot of people in cities would quite like to have that manual.
Yes, yeah.
Did you find that useful?
Very useful, extremely. It's your Bible. It's your Bible. But you always ask, there's always generally other nurses there with you. If they're not there at the time, you've got telephone support. You can call for backup help from your managers. You can speak with the DMO, the doctor on call and everything. Yeah.
So there's always somebody there. I mean, some people would say, look, it's a bit frustrating because you don't develop long-term relationships.
True. That can be a problem. But then that's a problem, you know, with myself going out and only being there for a short time. You can't form those relationships. Sometimes I've been back to a community several times and people there do remember me. But again, they're not really long-forming relationships.
Because in Aboriginal communities, they're based on trust and knowing who you are.
Yeah.
They want to know who you are, what your relationships are, where you come from, and so on. And that, in Aboriginal communities, you've got to earn that. It doesn't come easily, and it's hard to earn that respect and trust in a week.
True. But I have also I've had feedback from certain people in the communities, and they just find that my friendly nature, you know, like I've been told I have friendly eyes, you know, so they've been able to come to me.
Look into
you know, and just that, you know, just being open and being welcome, you know, welcoming these people and not being standoffish and say, well, you haven't done something right, you know.
Right.
Just treating them with respect.
Had you dealt with many Aboriginal communities before, or people from the Aboriginal community in your clinical practice prior to that?
No, only a few people coming through.
And did you get any training in cultural safety and just?
I did, yes.
So I think that was pretty essential.
It was, yes, definitely. Yeah.
Tristram, just to describe your service in central and far, central? Well, is it central west or central and far west, New South Wales?
At the moment, we're central west and northern central.
So it's Dubbo, Orange, Coonabarabran.
Yeah, Dubbo, Orange, and reaching up Coonabarabran all the way up to Lightning Ridge and the Queensland border.
Right.
And then out far west out to Cobar Burke. And our southern border, where we're currently reaching,
it's only the size of half of Europe, you know.
Only just
And describe what sort of service you provide.
So this is a newer service that's I'm currently developing.
You were a nurse before you became a doctor.
Yes.
Right.
Yes, I was.
And now you're a psychiatrist. But You thought this was, you know, playing with your psychological health a bit, so that, you know.
Yeah.
Anyway, carry on. So to tell us more about the service.
So this is one of the needs that we identified. I've been previously involved during my training, which I did for psychiatry at Orange, and we were working with acute telepsychiatry services, so providing just acute assessments. But it was noticed that there was a lot of, for want of a better word, subacute need. So patients or clients who were having developing mental illness that required some subspecialty assistance in regional and remote towns, but weren't able to get access to those services. So these include things such as psychiatry and allied health, senior social work.
So these are people with the full range of mental health problems, from depression and anxiety through to psychosis and drug and alcohol problems?
Absolutely.
So anything referred by general practitioners?
Referred by general practitioners, but co-case managed, so the patients who we are looking after or intend to look after will be looked after by primarily by the community mental health teams that are existent within the community, and we provide augmentative care.
Right.
So where there's an identified need that can't be met within the local community, we would provide that service.
So it's a true consultation or consultation liaison service?
Yeah, running along similar lines.
So how much are you in a plane, a car, versus on Skype doing a telehealth consultation?
At the moment, it's more trending towards telepsychiatry, and so using video links or and providing support through those methods. But there's a component of drive in, drive out, or and also looking to utilise some of the other existing flying services that we'd be able to piggyback on if possible.
So give me a sense of your week.
My week at the moment is still looking at developing this model,
Right.
and so a lot of what we're doing at the moment is around the needs analysis. So instead of saying, for example, the requirements for Burke are exactly the same as the requirements for Lightning Ridge, so we'll do exactly the same.
So you're asking communities, or are you asking the teams to identify the needs?
Initially, we've done a broad consultation across the area, but now we're looking at the specific towns and looking at going across the town. So say, for example, in Burke, we would be looking at talking to both the communities, the teams that are there, the NGOs, the local hospital districts, and just trying to build a picture of what's available.
So how much of your objective is, you've got somebody who's having an acute psychotic episode with a history of chronic psychosis, and they don't know what to do and how to manage that, versus sharing the care of somebody so that you leave greater skills with the community mental health team or the local GP?
Both parts are a big part of this project. I mean, we're certainly aware. A part of those acute services are already provided by some of our existing framework, such as the MECRAP service, which provides the acute telepsychiatry links. But part of our model will be looking at increasing the capacity of the local community to be able to deal with issues as they arise. The idea, I guess, being that we create a stable senior workforce that can provide these augmentative strategies or services, as well as education and resources.
So to what extent do you have your own patients in this sort of model?
Within this, the primary care of the patient remains with the community mental health.
So you're purely consultative, really. It's always
to a greater or lesser extent.
whether or not so. In fact, it's truly fly in, fly out, because whether you're on a video link, or whether you're on the phone, or whether you're driving in and out of a community, you're really doing that on a one-off basis to help the local team look after somebody better.
Absolutely.
So it's only when somebody needs to be scheduled and brought into the acute ward that you really get involved in the longer term.
We would hopefully be actually involved before then. So the idea is to detect that
to
need
minimise your
beforehand.
seclusion rates,
Well,
your restraint rates.
To minimise the impact of mental illness on the client, on the patient, so that we can get in there before the acuity rises.
And your relationship with the communities themselves, that must be difficult to develop. You rely on the local teams to do that.
We're looking at certainly we rely on the local teams to have that local contact, and certainly that can't be minimised. But part of our role as well is to be more involved and to understand, so that if, for example, something happens to the community teams, we're able to continue that service and continue that support.
Don't forget, if you want to make a comment or share an experience, why don't give us a call, 1-800-817-268. We'll put you on air. Don't be frightened. I'll be very gentle with you. But if you wanted to do it not anonymously, you know what I mean, you can send us an email, questions@rhef.com.au, or you can actually text us on 0408 408 932. It's on your screen now. Tonya, how long have you been at this?
Currently for about 3.5 years with the Flying Doctors. Before that I was overseas with another organisation, also working in remote communities, which I guess was kind of fly in, fly out for 6 months at a time and then leaving again. But yeah, 3.5 years going to the one community with the RFDS up on the Cape.
Just one community?
Predominantly one community. We cover each other a little bit, but most of our team of doctors have a community that we regularly go back to, so that we're a regular GP service. So, and our work's it's a mix of providing the general practice service as well as the after hours on call, as well as the retrieval service.
So you're not working for a community-controlled organisation, you're working for RFDS,
correct.
but into an area where Epinepimod doesn't serve.
Yes, so the Queensland Health clinics, which don't have a medical officer for whatever reason, and we're filling that gap in terms of having a GP service. Some of them, Epinepima is also providing a chronic disease service, which has started to come in now with a regular GP targeting chronic diseases.
So you're effectively the regular GP for a community.
Correct.
It's just that you don't live there 7 days a week, 365 days a year.
Yeah, exactly. And I think in essence, you know, while Christine was talking about the fly in, fly out in terms of replacing staff who were there and the difficulty of making relationships with the community because you're there for a short term. In fact, if you have a fly in, fly out service with the same doctor going back for 10 or 15 years, and it protects you from having, you know, someone going for 6 months or 1 year and then leaving again. In actual fact, you can build better relationships with the community by having a single GP service consistently, continuously, and actually form relationships with the community and start to have an impact on chronic diseases, which is one of the biggest issues up there.
So what does the community think when you fly home at the end of the week?
Yeah, I guess it...
So you're there Monday till Friday or what?
It varies from community to community, so it depends on the number of people in the community. Some of them are quite small, you know, only a few hundred people,
so
they don't need a doctor 5 days a week.
Right.
So it's targeted according to the size of the population and other services going in, depending where there's a
So you're not just going to one place, you're going to several places but in one area?
So for RFDS on the Cape or in Cairns, we cover about 14 communities. So, and some of them will be 2 different communities a half a day each, and some of them will be the same community for 3 days. So
right.
You fly and stay a couple of nights and stay in the same community, so it varies a bit.
So when you started, what did it feel like leaving them for a few days?
Yeah, I mean, it's odd. I guess a GP doesn't go into the practice on a weekend either, so in some respects it's normal to have a normal working week as a GP. I think the handover and the transition of care to a different doctor when you switch over halfway through a week, that's needs to be very complete and very well done to avoid that, you know, you weren't able to stay and follow through what was happening to a patient that you were worried about and making sure.
So where are the medical records?
They're kept in the community, the property of the Cape Clinic. Yep.
So there's no electronic storage here? You're not going to PCHR or anything like that?
Not yet. We are in the process of transitioning, but I think we're one of the last places in Australia not to have general practice with an electronic medical record.
So do you tell me how you do handover?
So you record in lots of places. So you record in the patient's notes. We have a doctor's diary where we transition messages to each other. We will send messages to each other or call each other up and say, can you just make sure you catch up with this person? We're worried about them. We pass on to the nursing staff and have a nurse's diary with messages to follow through. So a multitude of places. There's databases where you record patients that you're trying to keep an eye on and track. So it really, you try and record in as many places as possible to make sure it doesn't fall through the gaps, but it is hard.
I mean, is it any different from being a GP in an isolated community, or can it be scarier clinically? I mean, you're having to confront clinical situations which get your adrenaline going.
I think anywhere you're working in an isolated community is scary but interesting. You know, I've had days where I've had a mental health issue followed by an obstetric issue followed by a very sick child followed by someone with chest pain. In just the broad range of skills that you have to bring as a rural generalist, I don't think it matters whether which community you're in. If you're isolated and you're the sole practitioner, you have to have that really wide range of skills, and that's part of the interest for me of working in these settings.
How long do you plan to do it for? This could be a career-ending question, of course. If no doubt the RFDS is watching.
Well, I've done it for a long time, so I suspect I probably won't stop soon. I think part of the issue is maintaining your skills. So I think you have to dip in and out a little bit and go back into more specific services and keep your skills up, be it in obstetrics, be it in intensive care, things like that. So I think part of the advantage of being in a pool approach like the Flying Doctors has is that you can take a period away and maintain your skills and upskill all the time.
You've got to be consciously doing that.
Yep.
Must play hell with your social life. Do you have a social life?
Yeah, I think the fly in, fly out does support a social life. I think that's part of the benefit of it and part of the reason I stepped away from the going in for 6 months continuously, because then you're in the community, and I think with the fly in, fly out you do get that possibility to go in, do your work and fly out and have a
see your friends and parents and so on.
life-work balance a bit more. Yeah.
So David, you're doing Retrieval now.
Yes.
But just give us a sense of your history in this area.
I've been working with Western Operations, Royal Flying Doctor Service, for 7 years. So I started off.
And before that?
Before that, I went through my advanced training in emergency medicine. So I'm a fellow of the College of Emergency Medicine.
Right.
Prior to that, I was, well, believe it or not, I was actually a gardener before I did medicine. So I have a background in multiple industries before I started medicine, went through advanced training. I'm an emergency physician. But my last...
So you got the tetanus spores off your hands before
absolutely,
you got into
I know how to wash my hands. And my last job as a training registrar, or subspecialty one, was with the RFDS as a retrieval registrar. And that was in Jandakot, Western Australia. And that gave me an insight into something I've come to love. So when I continued on in Queensland with my advanced training in hospital-based, and then I took the opportunity to go back to RFDS on a fly-in, fly-out, although I never recognised it as that term at that time, in 2006, and been doing it ever since, principally providing relief to the 5 bases of Western Australia. So slotting into whichever roster needed staff relief.
Doing acute work or doing general practice work?
Initially doing both. So I was doing clinic work. Whatever that gap on the roster implied, I would do the clinics that doctor who was away at the time was scheduled to do, as well as the retrieval work. With time, that I've actually evolved that into a position where I actually just do the retrieval work now, because I find that for continuity of care, the base doctors, which are all residential throughout Western Australia, by and large, they go to the clinics week in, week out, and so I take over the retrieval.
So that's more like Tanya's role.
Exactly. So I sort of provide a retrieval role on top of that.
So I suppose as an ED physician, you're used to the transient relationship with patients rather than what GPs get their jollies from, which is the continuity with a family.
Absolutely. I think, different people are drawn to different aspects of medicine, and certainly that's my ED training, and my retrieval practice is certainly that. Having said that,
Are you a bit of a loner? I mean, do you like the loner's life?
Well, definitely. I wouldn't. I think my wife would say I'm not. I've got 4 children, teenagers included.
Okay, that's why you spend all your time in the air then, is it?
I spend probably half of my year at home, or just over half, and it's full-time dad. So.
All right, so you're at home more than most then.
I am indeed. I've done the numbers, and I am home a lot. So, but when I'm away, I work intensely away. I work 6 or 7 days a week, and in doing so, I feel like I provide support to my colleagues, and the advantage of the community is that my colleagues then get breaks. They get time away for the education that's been talked about. They also get time just to chill a bit, but also stay with their clinics, rather than having to abandon their clinics for the time that they're away and having no one relieve them.
And how do you organise your CPD?
It's complex. It's the fact is that I have substantial, like the others here, have substantial requirements to keep up my CPD, and so I endeavour to go to conferences, workshops, and so on while I'm away from home, and try and integrate that into my travel, because as you can imagine, I travel an awful lot. So this 3 weeks away is a classic example. I'm on a full-time roster in Jandakot and Perth at the moment. I sneaked away 2 days to come here. I've got 3 days at a conference in Melbourne on the way home, and I'll get a 2-day workshop on the Gold Coast before I even touch home. So that's at the same time as committing myself to the roster that I do and achieving that. So it's busy. It's very busy.
And can you see yourself doing this indefinitely?
I've been doing it for 7 years now, and I can see myself doing it for another 7 easily.
So can you tell me some memorable things from your early times that you thought, I never thought I'd ever see this type story?
Absolutely. There's many cases. Float plane retrievals to the remote Kimberley. running resuscitations down telephone lines, organising extractions of people from remote stations in the Pilbara. The logistics of my work is what fascinates me as much as the actual flying.
And are they flying jets these days or still propeller?
Well, the majority of the fleet across Australia is turboprop. We have one jet in Western Australia, and it's pretty much a watch this space in the coming years.
So it's no longer the little single-engine Piper, landing bumpily on...
No, the bug smashes are pretty much, a thing of the past, which actually changes our input into remote communities in a substantial way.
So has that limited your access then?
It limits it to the point where the upkeep of airstrips is very important in terms of being able to get our bigger aircraft into those places. For clinics, that's a different story. Obviously, they are using smaller charter aircraft, piston-driven aircraft. But for remote retrievals, the classic, station retrieval requires the station owners to keep their station strips up to scratch. And sometimes when that's not done, there's a necessity to move patients on the ground to a point where we can retrieve them from. So it adds to the complexity and the interest of the work.
When I was a paediatric registrar, you had to go on the roster for paediatric retrievals. This was in New South Wales. You can still remember, I can still remember the cases, and you'd fly into somewhere like Grafton in the middle of a storm, and there'd be a baby with pulmonary hypertension, and the ambulance driver would say, "Have you ever been to Grafton before?" and insist on taking you on a tour of Grafton before you actually go there, and then you got to ventilate this baby on the way back. But I suspect it's a bit more sophisticated these days than in those days.
Well, the back of the aircraft is a mobile ICU unit, and it's becoming more sophisticated with time, and that's changing around Australia, indeed as it is
Which is
around
why
the world.
the aircrafts are bigger and presumably safer.
Correct.
But why you need ongoing upskilling as well.
Exactly.
All the time.
Because there's more and more kit on board.
And why I find myself heading more towards retrieval as opposed to try and manage all the skills of general practice and so on.
We've got a few questions coming in on the webcast. Don't remember, you can go to the webcast if you like it, but if you're already on it, just click the live talk tab and then submit. Or if you want to go onto the webcast, go to rhef.com.au and then log on. Melanie Walker from South Australia asks, how can professionals be attracted and retained to do fly-in, fly-out work? And DIDO, what's DIDO again?
Drive-in, drive-out.
Oh, drive-in, drive-out, right, okay. Depending how fast you drive, it could be FIFO as well. Anyway, what successful models are the panel aware of? What have you seen around the place? Might ask Tonya and David this question.
I think the most successful model in terms of fly-in, fly-out is to have, and I don't think it matters whether it's fly-in, fly-out or resident, is to have a really comprehensive primary healthcare service, and then to have the specialties coming in and supporting that. But I think if you have a good comprehensive primary healthcare team, they can manage a lot of what you'd need a fly-in, fly-out specialist to try and manage. So I guess for me, what works for us is having a pool of doctors who all know the Cape, who can all cover each other so that people can maintain their skills and things.
But Queensland has some interesting models. I mean, there's a group of GPs, I think they run out of the Sunshine Coast, who go into quite remote communities, provide a standard general practice service in private practice, and go home to Noosa at the weekend.
Yep, and I think there are places where GPs have their regular practice and then go out and do, for example, a lot of the Women's Health Service, they go out and provide the GP service intermittently in other locations, but still have their base practice somewhere more central as well. I think a lot of the allied health services are fly in, fly out in support of the team on the ground. So I think you need a well-supported team on the ground, and then whatever additional needs there are to be supported with a fly in, fly out. But the team on the ground, or the primary healthcare team, doesn't have to be resident necessarily.
But sometimes they don't exist.
I think any model that provides a continuity of care, even if it's with somewhat changing faces, is very much accepted by people, because that's what they want. They want ongoing care.
Yeah.
But in Western Australia, it's not necessarily always to remote communities.
No, it's not. I mean, I certainly know a group of emergency physicians which provide 7-day-a-week cover, for instance, in a regional hospital like Kalgoorlie. which is an evolved practice. It's obviously outside the RFDS's work, but knowing those guys personally, they provide a very important specialist level of care to a community that not that many years ago never had that. So, and they are, none of them, as far as I'm aware, are resident in Kalgoorlie. They're Perth specialists, they work in the Perth tertiary hospitals, and that they spend time on their own roster going to Kalgoorlie and providing that level of service. So I think that's one of those under the radar type fly in, fly out things that people aren't aware of, that's contributing greatly to regional health services. Another example is, Tonya alluded to it, was the Rural Women's Health Service that is run by the RFDS into the wheatbelt towns of Western Australia. And that is not to take over from the local GP practice, but to supplement them, and they actually work within the practices that are already established, and by doing so they give those GPs both support or a chance for a break and so on, and they're the
and local women a chance to see a
and
woman.
gender choice of visiting doctor, and they've been doing that for years, again, and and possibly for much of the community unaware that actually happens.
Have you seen many alternate models that you're learning from in terms of psychiatry?
Well, certainly. I mean, there's one of the first models that we looked at when we were looking around Australia was looking at this South Australia model. They've been running certainly for a long time under Ken Filkey, where a lot of
that's where Peter Yellowleigh started. No, I think Peter Yellowleigh started the very first telehealth service for psychiatry in South Australia.
That's right, yeah, and they've been running that service very successfully, and I mean, as they often quote all their psychiatrists. I apologise if I'm misquoting now, but all the psychiatrists are located within the Adelaide region, but still provide a complete outreach service from that one site. And so certainly looking at some of their models and what they've been doing, we've been able to learn from such as a lot of their fly-in, fly-out services and subacute work that they've been doing. But even within our district, I mean, we have a number of services that are running, that have been running for quite a while, a number of psychologists that have been flying or driving out to various places such as Burke and Cobar from our major regional towns to provide these outreach support and services.
To what extent are you in mental health using online? I mean, when the people who develop the online therapies, Mood Gym, people at St Vincent's, CRUFAD and others, say that really in many ways they've designed it for people in rural areas who can't get access to healthcare practitioners, and in fact arguably provide better care because it's high fidelity care to cognitive behavioural therapy than experienced therapists do, because the computer doesn't deviate. Are you encouraging people to actually do online therapy for the high prevalence disorders?
Absolutely. I think they're just one part of the whole armament that we've got to
But you're
use.
consciously doing that? You're recruiting people to do that?
Yeah, I've certainly used. I'm already registered to prescribe on CRUFAT and utilise their services, and have used them on occasions where it's been useful, where in those cases psychological intervention on a regular basis wasn't available, and I was only able to visit and telelink on limited occasions, and so having that available is a good option. But I think it's just one part of all the tools that are being looked at, and certainly used in my clinics in the past.
And are you finding more rational prescribing? Because there has been criticism that the less experienced you are, the more likely you are to throw around things like haloperidol and olanzapine unnecessarily. Are you finding that you're getting better quality use of medicines?
It's short answer is yes, but
I think yes, wouldn't it?
But I think it's multifactorial, and part of that is around making sure you've got your own level of peer supervision and ability to be able to reflect your practice to others and ensure that you're remaining in line.
The other thing, of course, is the danger in specialist practice is, people with schizophrenia have a reduction in life expectancy of about 25 years, and it's not suicide, it's cancer, heart disease. It's basically that they're not getting good physical care. And the risk is with fly-in, fly-out psychiatry services, you become even more fragmented from physical care, and you're actually not getting them healthy.
It's a big problem, and it's something. For example, it's a project that's running within the area health service for us at the moment. I believe it's at least statewide in New South Wales Health. Is, for example, with schizophrenia, looking at metabolic syndrome, and there's a whole.
Olanzapine again.
I think you do need good GP services as well. I think that still comes back to having
that's
good
my
GP
point.
services.
The Ontario model for psychiatry outreach is the psychiatrist sits in the general practice surgery and sees cases that the people that the GP has referred, but the GP sits in and actually gets upskilled so that as time goes on, the psychiatrist is seeing more and more complex cases, more appropriate to the psychiatrist, and the GP is doing far more. And you get more integration with physical health, as Tonya was saying. I mean, is that a conscious strategy on your part, or you're just so swamped by the regular mental health stuff you're sinking?
There's a lot of need out there. But there are certainly those models that are currently operating even within general practices, a lot of which is being supported by some of the newer Medicare initiatives of using telepsychiatry, where there's a number of
so you are sitting with a GP then often, yeah.
Exactly. Yeah.
And presumably going into remote Aboriginal communities, Christine, you're not really seeing many different models. It's usually either a community-controlled organisation or a local primary health service with Aboriginal health workers.
Yeah. So if we have needs that come through like that, we do a lot of referrals. So when clients come in, if they've mental health issues or something like that, if there is a doctor in the clinic, we can actually refer to the doctor there and ask them to review the patient, or we can do a referral for when the GP or psychologist comes into the clinic.
So we've got some more questions here. Another one from Holly Parker, Edith Cow in Western Australia. Hi, I'm a student nurse and I'm curious to know what services in Western Australia provide fly-in, fly-out services to which communities? So it's a perhaps more generic question than just RFDS.
Yeah, indeed. And I'll be honest to say the breadth of those services that nurses may be able to take advantage of beyond my knowledge base. The fact
is there a place that Holly can go to find out?
Almost certainly, but I can't put my finger on that.
Right.
I apologise. But the truth is, there are enormous, and perhaps Christine can help me out there. But I liaise with enormous number of remote nurses and nurses within regional facilities, and they provide a huge service, often without the immediate backup of a doctor in the community, and so there are enormous opportunities outside of the RFDS.
So Holly, probably also you want to talk to the Remote Nurses Association. That is CRANA, isn't it? Or it's
one of them. Yeah.
Yeah, and they probably will be able to put you in touch with the right people. But it's a good question.
If I could be a little bit more anecdotal, someone like Holly could simply speak to her colleagues, because they'll know people who work in those fields, and she'll probably be able to make personal contact and get some insight into those different places. And
also through her university. So for clinical placement, she can ask to be placed in a remote community or a rural community.
Within RFDS, we do have fly-in, fly-out nursing staff as well, but they're certainly not new grads. They're flight nurses with a broad range of skills, which takes some years.
Which is really the next question from Belinda O'Sullivan at the School of Rural Health in Bendigo, Victoria. What sort of professional development? Oh, well, actually, it's a different question. What sort of professional development do the local workforce need to cope with fly-in, fly-out? Well, let's answer that question. We'll come to what professional development do you yourself need before you take on one of these jobs. What do you believe, I mean, from your point of view as a nurse, looking at the people on the ground that you go to work with, what do they need specifically to be able to handle that intermittent person who comes in and out?
Probably just to be able to accept the person to come in, and
it's about relationships.
Yeah, and to let them, we're coming in to give them a helping hand and trying to relieve the pressure from them so they're able to get out and about. I mean, I know they can be very stressful at times for the staff on the ground, and things are just like, And
Tristram, you've already said you're trying to build up community-based teams so they're as strong as possible, and presumably recruitment is a huge issue.
Absolutely, and I guess around it all is identifying need and making sure that what the outreach teams are doing is actually helpful and needed by the community, and I think that helps in the collegiality between the teams that are already in place and those that are flying in, flying out, to actually make sure that it's meeting need.
Tonya?
I think you need really good understanding. It's a very two-way street. You know, it's hard for the residential team to have a fly-in, fly-out team suddenly arrive and start to say, you know, I need this, I need this, I need this, and actually increase the workload of the team on the ground when they should be supporting them and assisting them with their work. So I think that's one for the fly-in, fly-out team, and then also for the team on the ground to understand that when you're flying out and you've got 100 things and you're trying to make sure that things don't fall through the cracks, and you know, you're feeling a bit under pressure because you've got plane to catch and you're holding other people up in other places that are also catching the plane and things like that, and you feel like as though you're just dumping and running, which is a terrible way to leave things. So I think you need everyone to appreciate what each other's roles is, how they're supporting each other and how they work together to make a good team, and to feel that you're all part of the same team and that, you know, you need each other to be able to function. So just that appreciation and understanding of what everyone's roles are.
Dave?
Yeah.
Well, I can only agree with what's been said, you know, and it also integrates what was said before about handover, clinical handover. That's equally important, so that there's a relationship between people staying and people going.
So what training do you think, up to what level of training do you need before you take on one of these jobs?
I think it's got to be throughout your training career to really, I mean, and that's perhaps from my own personal experience, but to have it not only for myself in my nursing training, but was also present in my medical training during my registrar years. And I think that equipped me quite well to understand.
So it's like anything else, it's the degree of responsibility you're going to take as a fly-in, fly-out doctor or nurse.
Some things you can't train for, you know. I think in my experience, especially flexibility, you know, I think it doesn't matter how much you try and train, if someone's very rigid, they struggle very hard in remote settings wherever you're working. You know, if you want people who are really flexible and a bit pragmatic, often tend to gel better in these settings where things will go wrong and you've got to be able to deal with that, then expect that you can control the environment and fix everything to the way you'd like it. And that's where I think they struggle a bit.
Yeah, I think we could probably all think of examples of colleagues who are good clinicians but just don't fit the mould for the remote environment, because one, they just may not feel comfortable with the being somewhat stranded, and whereas other people are infinitely comfortable with dealing with what they can see in front of them to the best of their ability, and then thereafter making the communication that's necessary.
In the same way, I guess, understanding what is available within the community and ensuring that what they're doing is actually, or what they're suggesting is actually valid and can be put in place.
We have teams that don't do fly-in, fly-out, and when you call them for advice, if they've never been up to the community, some of the advice you get is really irrelevant to your setting.
Right.
And so I think
So
the
get
fly-in,
theatre
fly-out
ready, call
does
the
it.
anaesthetist.
Yeah, where's your CAT scan?
I think
okay,
a
I've only
good
got an MRI.
regional and remote clinician, be they a nurse, a doctor or it's allied health, knows how to communicate with other people, because they'll at some stage be out of their depth, whether it's relatively simple but they just don't know it, you've never seen the condition before, or it's something complex and they just need help. You know, one of the things I love about my job, one of the many things, is that I can pick up the phone and anybody will talk to me because they'll be interested. And you know, that's a big bonus.
Another question from Bendigo is, what about accommodation? Is that a challenge?
Well, everywhere I've been to so far, I've had clean, secure accommodation, self-contained. You take your own food in, and it's been good. I've heard horror stories where people have rocked up and it's just been a condemned, you know, little building type thing. You know, they've chosen to stay on. Others have totally refused and said, "No, I'm not staying here until I get better accommodation."
Yeah, and Queensland Health got into Tiger Country over, was it Palm Island, or accommodation in Palm Island at one point?
Yes.
Yeah.
See, I worked in Africa for a long time, so I feel a bit Python-esque and say it's luxury. You know, it's pretty good in most of the places. There's always problems with maintenance of accommodation. I think there's huge problems with amount of accommodation. I think a fly-in, fly-out workforce, a lot of people need accommodation when you get more and more services, and that often limits services as just the lack of accommodation. But I think the quality and the standard, from my experience, have been pretty good.
You just sleep on the plane.
I try to at every opportunity, but I've also, experienced excellent accommodation just across most of the places I've been. But I also know about the horror stories as well, which are relatively few and far between. I think it's incumbent on the organisations who set up the programs to provide the clinicians with accommodation that it doesn't have to be substantial, it doesn't have to be luxurious, it has to be clean and secure.
Secure, yeah.
And another question, do you think the local workforce is more likely to be retained and stay on by having fly-in, fly-out into the community, or does it not make any difference to their intention to stay?
I think one has to once again complement the other.
I suppose if you feel supported, in the sense that you're supporting the local teams,
exactly,
you feel better.
That's precisely what we're finding, is that the teams that are isolated and not receiving that external support are more likely to find themselves feeling stressed or burned out. And so having that extra support, whether it be personal mentorship, education, or assistance with difficult cases that they're finding a struggle, is really important.
And I suppose in your case, Christine, where you're relieving people, that gives them a break and refreshes them when they come back.
It does, yes. And I mean, I could relieve them for their annual leave or go in for relieving them for their education.
Yeah,
so although it was short time frames that I do it, it's still...
It's just not about service provision, it actually has all these other side effects or benefits.
Yeah.
Respite, professional development, support.
Absolutely.
And a question from New South Wales, from a physiotherapist. Is there fly-in and fly-out allied health?
We'd love a physiotherapist on the Cape. We don't have any. Come on. We have one OT, and we have huge gaps in some of the allied health. We have good support for dietitian, diabetes educator, podiatry, optometry is okay, but the OT and physio is really one of the biggest gaps we have, to be frank.
How would they be paid if you got one available? How would RFTS put them on a salary? Would they charge private fees? How would it work?
Essentially, most of the allied health.
So okay, we're committing RFTS here now.
Most of the allied health are through Queensland Health.
So Queensland Health would fund the
Queensland
position if they managed to find one.
As far as I understand, there is an open position.
Right. Okay.
I keep being told.
Okay. Good. And so you've got allied health people supporting community teams?
Yep, we're very proud. We've got we've managed to secure an occupational therapist, and we're gradually opening up more and more positions to be able to get psychology, social work, and specific DNA CAMs to provide that extra support and service to the local communities and the community mental health teams. So that's certainly a roles in development.
So a nurse, Matthew Justin, writes, retrieval specialists, locum relief or visiting consultants have always been a part of rural and remote healthcare. However, the changes towards fly-in, fly-out, month-on, month-off employment, even in so-called resident healthcare teams, this has an impact on continuity of care. Discuss is his demand.
I think Tanya alluded to that before, how that continuity of care can continue despite the fact that there's changing faces on the team.
Yeah, I mean, on average, our team, we have some doctors have been there 20 years, 15 years. Our average is 8 years. So I think in actual fact, your continuity is actually better served through a fly-in, fly-out model or a month-on, month-off model, things like that, purely from experience now.
Rather than a locum who would come in for a couple of weeks and go off again.
And even the residential nursing teams, you often see 6 months, 12 months maximum, and then majority are leaving. There are a few who stay and love the community and are fantastic and provide brilliant long-term continuity of care. But it's becoming fewer and further between. And we recognise that for all of remote Australia, where we have struggled for medical services and healthcare services in all settings purely based on the difficulties of family support, lifestyle and ability to stay permanently in small communities. So, and some of the communities are too small to have permanent living continuous presence, you know, be it Breast Screen that does a drive around service because, you know, you're going in once a year to do an entire community, things like that. Some of the services do not need a permanent living presence, so, and they're best dealt with through either, you know.
So your argument is that it improves continuity of care?
In my experience, certainly improves continuity of care. We have really fantastic continuity for our medical teams.
Amongst the, on reflection, just even looking at my own experience with specialists flying in and out both from Sydney and from Orange and Dubbo out, the consultants that have been doing it for 20 or more years. And I guess what's apparent is that once, it's almost like they fall in love with the regions that they're working with. They become very enmeshed. And know the communities, are able to respond to the communities quite well and advocate very vocally as well during meetings and otherwise for retention of those services and for the services for the region. So I think it provides a level of, I do think that it provides continuity, but it's a different picture.
Yeah.
And I guess particularly as perhaps we mentioned before, that being able to base consultants, specialists in smaller regional towns don't necessarily have the capacity to be able to provide all the work that would be able to retain a specialist in that area.
This doesn't give the volume.
And so FIFO and DIDO and all the other acronyms for moving in and out of places provides that service on a regular and consistent basis.
What do you think, Christine?
I find that there are issues for myself as a nurse, but where I'll try and carry it through is I'll go in, I'll use the systems that they have in place, pick up the area and sort of carry it across. So in doing that, when the permanent nurse does come back through, she'll be able to see that the care is just carried on.
And of course, handover is really important.
It is, yes.
So you should really be encouraging a bit of overlap so that
Yes.
you can actually talk to the person coming back so that they know.
And sometimes if we can't talk to the person because, you know, you've overlapped, you've flown out in the morning and she's come back in the afternoon, or he, there's the diaries and there's the other communications. We've got electronic communications as well on the files, etc., so we can write notes and what we've done and everything.
You're better off than RFDS then.
Your question.
Queensland Health, I'm sorry.
NT Health.
The person who asked that,
Carly Sutherland, our South Australian psychologist, asks, what personal qualities or characteristics are important in health professionals who provide services? Well, I think you've said it. It's really, if I've understood you correctly, flexibility, good communication skills, patience, and expect the unexpected.
And good to have some clinical knowledge. I think it's important.
Oh, just a little, really?
Yeah,
Oh,
I'd add that in.
that's a bit old-fashioned,
yeah,
isn't it?
I know.
Another question from Matthew Justin. To staff any organisation with FIFO employees means recruiting more individuals than if they were all full-time. Is that true?
To some extent, we have more part-time staff, so we have 26 staff covering 18 full-time equivalent. So,
and
but
so Justin goes on to, Matthew, I should say, goes on to make the point that with the increased number of staff, you've increased the number of handovers, and the opportunity for diminished quality.
Yeah, the possibility for drops in care for patients to be dropped, and that's where you have to be more exact about it and more thorough about it and really pay attention to it. But I think that can happen no matter what, and I think either way you have to be extremely diligent about following through, and I think that's true of general practice. I think that's somewhere where hospital training versus general practice training are quite different, because I think hospitals, we do a lot of handover. In emergency department, every 8 hours you have a handover shift, or every 10 hours. So you have a different team come on, a different team come on. So within the single episode of patient care, you have multiple different teams looking after a patient. So I think hospitals are really set up for that rapid transition, handing over all the time of patient care. So you just have to pay attention to it and be aware that's the model you're working in and make sure that it continues to happen.
The evolution of information systems is helping that process out. There's no doubt about that.
I had a question for you here. It's disappeared, David, but it was from Liam O'Doherty, if I remember rightly, from a Victorian general practitioner, asking about whether or not the Faculty of Emergency Medicine is coping with these sorts of skills in its training process.
Specifically with respect
for retrieval. Retrieval.
Absolutely, with respect to retrieval within the training program, retrieval is a subspecialty opportunity, which obviously not everyone does, but you can do it for 6 months. You could do it for longer if you want, but you can get 6 months recognised. That's exactly what I did, and then you can take it from there. It's a burgeoning field, retrieval, not only within Australasia but worldwide, and so there are actually lots of opportunities to continue that education. But specifically within the college, there's you can have that accredited, for sure.
I think I'll come back to my continual point. A good GP can also manage a lot of the retrieval services in our setting.
I'll add that I'm the only specialist emergency physician doing retrieval work for the RFDS outside of Jandakot. So they're all generalists, and they all do a very good job.
I think that a lot of the remote work, you need a rural generalist. If you tried to put an emergency physician, the same as Tristram was saying, you can't have a psychiatrist in every small community. You can't have an ED physician for every small community and things like that. And a lot of the retrieval, emergency work happens with our clinic staff who are sitting in a clinic, and suddenly the patient arrives from the rollover or whatever, and you have to manage the patient immediately and be able to manage that without necessarily waiting for the emergency retrieval physician to come out and help you.
That comes back to your question about what skills people need. People need to be comfortable with dealing with those sorts of emergencies and not be too naive as to what might come through the door. So, and that may mean that you need to have a few years under your belt, unless you're particularly cocky.
It's been fascinating. I've learned a lot. What are your take-home messages for those watching who could be aspiring physiotherapists, fly-in, fly-out physiotherapists, occupational therapists, pharmacists even, and general practitioners and nurses? What's your take-home message?
Well, mine is certainly maybe two-pronged. One is the fact that there are a lot more fly-in, fly-out, drive-in, drive-out type services out there and that significantly contribute to regional and rural, remote health than one might suspect. So if you are thinking about doing it, then certainly speak to colleagues, and because you may find out there's niches out there that have already been taken advantage of.
Tonya?
I would say essentially you need continuity of services and good generalist services, and I think fly-in, fly-out, in my experience, addresses a lot of that need.
Tristram?
I'd suggest if you're doing it, take your time to know your community and to know the people that are working in the community, because they can be your greatest ally.
Christine?
If you're keen to get out there and try some remote nursing, I would say definitely get out there and have a go.
Exciting.
Because you'll never know if you never go.
Know. That's right. It gives you a bit of independence and a lot of confidence. Look, thank you all very much indeed. I hope you've also found this programme on Fly-in, Fly-out, a healthcare option, informative and useful. There are plenty more resources and websites available on this topic, and we've put some on your screen, including the CRANA website if you're interested in obtaining more information. And of course, you can always go to the Rural Health Education Foundation website, where you can watch this programme again or get those resources. And if you want to watch the programme again, click on the programme page, Fly-in, Fly-out, a healthcare option. If you're a health professional, don't forget to complete your CPD evaluation form, which can be completed online. You'll receive a certificate of attendance and, if eligible, CPD points. Our thanks to the Department of Health and Ageing for making this programme possible, but a special thanks to you for taking the time to watch and contribute to our discussion today, including you, Matthew. We'd appreciate your feedback on the programme. Your comments are very important to us. Let us know you watched the programme by sending us an email, text or tweet, and feel free to share your views. We'd love to hear them. I'm Norman Swan. See you next time. But please join us again on the Rural Health Channel.